Hello friends, now I will talk about the PCOD. What is PCOD? PCOD basically a polycystic ovarian disease. In this we will discuss about pathology, clinical features, laboratory findings and criteria of diagnosis, that is called as Rotterdam criteria, treatment and complication of PCOD. And some questions are also discussed here. If ultrasound finding of ovary is normal, then still patient have PCOS or not, and drugs should be avoided in hirsutism, and some case scenarios will also be seen here. Now go on to the next slide of PCOS. So what is PCOD? Polycystic ovarian disease is an ovulatory and reversible cause of infertility. How it is reversible? Because it is treatable cause of infertility because in PCOD patient is infertile but can be treated. Now the pathophysiology of PCOS. What happen? Mostly the patient is obese. In obese patient can be obese or not be obese, but mostly the patient obese, and there is a peripheral conversion of testosterone into estrogen, and estrogen is by the enzyme aromatase, and estrogen is E2. The estrogen that formed is E2. As we also know that in postmenopausal women the main estrogen is E2, but in reproductive age group the main estrogen is E1. In reproductive age group the main estrogen is E1. In pregnancy the main estrogen is dominant estrogen is E3. But in pregnancy also E1 is more, but E1 is also there in pregnancy, but dominant estrogen is E3. Now go to this topic. Estrogen is E2, E1 is not there, so as we also know E1 is more functional, but here there is E2. So when there is no functional estrogen, there will be no LH surge. When there is no LH surge, there will be no conversion of primary follicle into the secondary follicle. When there is no conversion of primary follicle into the secondary follicle, there will be no rupture of follicle, and the follicles will arrange in the side of the ovary just like a necklace pattern ovary. Now we will see about the clinical features of PCOS. Clinical features of PCOS. What happen in PCOS? There will be patient can be a girl comes to you with acne, with hirsutism and with irregular cycles. Now as we have studied the pathophysiology, now we will let's study the reason of the acne and hirsutism. As we have studied in obese, there will be more testosterone. Testosterone will in the peripheral tissue, testosterone will be converted into the estrogen. More testosterone is the cause of acne and hirsutism in these patients, and irregular cycles because there will be an ovulation cause irregular cycles. And in females, in reproductive females, when they there will be infertility because of the anovulation. Now we will move into the lab diagnosis, means what findings are increased and what things are decreased in PCOS. So let's study lab findings of PCOS. In lab findings, there will be increase of androgen, testosterone. There will be increase of insulin because there is a insulin resistance, and in insulin resistance, because of the feedback, there will be more production of the insulin, and there will be reversal of the E1 and E2 ratio. In normally E1 is more, but in this E2 is more. So but estrogen is more in these patients. Surprisingly, estrogen is more because more E2, but functionality is decreased, and there will be increase in the level of LDL. Androgen increases the level of LDL and decreases the level of HDL. There will be increased estrogen. Estrogen has a negative feedback of on FSH, so FSH decreases. There will be an ovulation, so there will be no progesterone, no LH, no progesterone, and there will be decrease in the level of HDL. As you have seen, there will be decrease in the level of HDL and increase in the level of LDL, so patient is a more risk of coronary artery diseases. Now we will study about the criteria of PCOS. The criteria is a Rotterdam criteria. How it is diagnosed? Rotterdam criteria. What Rotterdam criteria says? Rotterdam criteria says that out of three, two should be present. And what are the 3 points? First point says that in increased androgen, there should be a feature of increased androgen. Maybe in the blood there will be increased androgen, or maybe feature of hirsutism. Point to be noted that there is a difference in the increase in the androgen and how much it should be increased. Clitoromegaly or some this type of feature should not be there. This type of feature is present in the tumors that secretes androgen. That tumor secretes androgen is in more quantity than this disease, so there will not be clitoromegaly, but hirsutism, acne, and this type of features are there. Okay, next, ovary. In ovary, there should be more than 10 centimeter cube size volume and more than 12 follicles, more than or equal to 12 follicles, and 2 to 9 mm. Follicles are small, but they are more in number because they are not ruptured, so they are arranged in the side of the ovary as a necklace pattern, so they are more in number. And there will be means after the LH surge also after some time, 48 hours, follicles increase in size, and after the increase of size there will be rupture of the follicle. But in this there will be no LH surge, so follicles are small and arranged in the side. And there will be irregular cycles, maybe maybe there will be decreased bleeding there, or maybe there will be increased bleeding, but there will be irregular cycles. There may be hypomenorrhea or oligomenorrhea, or there may be next we have to we will see about the how the ovary looks like. So as you can see, ovary looks like as a necklace pattern. In the side of the ovary there will be more follicles. And first you have to see this point in mind, that necklace pattern is not in the criteria of Rotterdam criteria. This is just a finding, but in Rotterdam criteria, ovary there will be more follicles, the size and all other parameters, but necklace pattern is not a criteria. This should be kept in mind. Okay, now the treatment part. Treatment. What has to be done in the treatment part? For acne and the hirsutism, cycles are normal, all things are normal. For acne, the treatment is benzoyl peroxide or other antibiotics, or other things for acne and hirsutism, spironolactone or other. But if menstrual irregularities is also there, then OCP is the best treatment for acne, hirsutism and menstrual irregularities, because OCP will take care of all the things. And for menstrual irregularities, OCP is the best treatment. And for infertility, the treatment is letrozole. Letrozole is a drug of choice, but clomiphene can be given. and the drug that should be avoided is danazole. Why danazole should be avoided in PCOD? Because danazole, the side effect of danazole is hirsutism. And next thing is of OCPs can't should not be given to those females who wants to become pregnant. For infertility, OCP is contraindicated. So so we have to be seen whether what type of patient coming to us, what are their needs, and how we should treat them. Now the complication of PCOD. Complication is in PCOD. There will be insulin, as we have seen. Patient is obese, patient have insulin resistance, there will be acanthosis nigrans also there, central obesity also there. So all complication of diabetes can be there in the future. Okay. Next thing, complication of CVS, as we have already said. LDL is increased, and HDL has been decreased, and central obesity and all just metabolic syndrome. So patient can have coronary artery diseases, stroke in the future. And osteoporosis, what should not be there here is the osteoporosis. Why? Because estrogen is more, as we have already said, and estrogen has a more effect on the bone. Estrogen is bone forming type hormone, so osteoporosis should not be there in these patients, because the function E2 and E1 has same function on the bone. And the next thing what I want to say is thank you. And if you like and your doubt has been cleared, so you can subscribe to my channel.